Hello, everyone. In this lecture, we are going to cover the efficient cervical spine examination and really the sequence that you should follow if your goal is efficiency. So first of all, let's define clinical efficiency, or this is at least our definition of clinical efficiency, and then why you should use this examination sequence. So clinical efficiency is quickly arriving at the correct physical therapy diagnosis and determining the appropriate plan of care without performing unnecessary tests and measures. And the reason that I think you should perform more of an efficient examination is that a lot of the things that we learned in PT school, they can be used at certain parts of the examination, but we never really learned how to put everything together in the most concise manner. And so that ends up where a lot of clinicians are performing multiple special tests that don't really add any final value to their diagnosis or to their plan of care. So this is kind of the cut and dry or the down and dirty special test or whole sequence that you need to perform. So the goal with this is efficiency. And we know that everyone is not going to fall into every one of these categories. On certain people, you might need to pick a few tests from here or there, or maybe you need to do one or two specific things. But for the most part, this will get you through the majority of your cervical spine examinations without doing too much. You can take a screenshot of this slide or print it off if you like, but this is the sequence step by step, and even the pre-examination portion is on there of some of the safety tests and measures. But basically, if the pre-exam is necessary, which usually I recommend it, do those tests first. Then most likely the patient is starting in a sitting position, so then you do your seated tests and measures. Most likely, if it follows a normal exam sequence, then you have the patient in supine, and then finally you have them in prone. And then after that, you should give them the diagnosis and start with the treatment. So it goes from sitting, supine, prone, and then right away getting into the most appropriate treatment and plan of care for that patient. Now, why the efficient exam? Well, let's start with special tests. So a big part of a physical therapy examination is performing special tests to help rule in or rule out diagnoses. Now, the current thoughts on these special tests is that we know that many of them aren't that special. So if you would take the Hawkins-Kennedy test in the shoulder, for example, the positive likelihood ratio for that test is about 1.5 by itself, which is really not very good. So using that test is not going to give you hardly any information. But then if you would cluster that test, let's say with the painful arc and the pain with the infraspinatus manual muscle test, all of a sudden those clustering of findings brings your 1.5 up to close to 11 on a positive likelihood ratio, which is actually a significant shift. So many individual tests are not that special. Special tests can also lead clinicians to more confusion. So when I was a novice practitioner, I would perform every test in the book. I'd perform, for the shoulder, I'd be looking at 5 or 6 bicep labrum tests. I'd be looking at tests for full thickness rotator cuff tears. I'd be looking at, tests for basically every diagnosis. So I'd perform 20 to 30 special tests. I'd document them all. It'd take a really long time. And then I'd wonder how those impacted my plan of care. And often they didn't really. So it kind of led me to more confusion, really wondering why I was even doing the tests. And on that note, special tests make it very easy to misinterpret the test results. So if you're testing something for the bicep and then they have pain in the shoulder region, we can be quickly led to think that it's the bicep, where the test, because of its low diagnostic accuracy, gives us a false positive, and then we misinterpret and actually provide a wrong diagnosis. And then finally, the tests often heavily focus on anatomy. So let's take the Hawkins-Kennedy test, for example, earlier, and we know that by itself isn't very good. And the Hawkins-Kennedy tests for shoulder impingement. Now, impingement is a catch-all term generally, so it could be that impingement could be due to a rotator cuff tear or to a labrum injury. But what if the person's pain, what if they've had chronic pain, and really the problem is more of a central sensitization, or it's more of a pain perception and processing issue, which it often is with people who have shoulder impingement. So the heavy focus on anatomy is not bad, again, if we're clustering our findings, because it can help hone us into a specific type of tissue. But we have to have the pain science and the pain neuroscience education, that piece following hand in hand. So reframing how to use the special test, know how and why to cluster them. We've talked about that a little bit. I would really recommend focusing in on why a positive test would impact your clinical reasoning. So if you are doing a bicep test, for example, and you have their hand in more of a supinated position versus more of a pronated position, what's happening to the actual anatomical structures that's making that test either more or less irritable? So potentially when their arm is up, the bicep muscle is being stretched more or stressed more on the front. But as you turn the thumb down and do it with a more pronated position of the hand, then we're actually stretching the bicep differently. So really more, instead of viewing it as a positive or a negative, understand what structures you're stressing and then how sensitive those structures are in certain positions. And then finally, if you don't know the purpose of a test, just don't do it. And that's with the exception of some of our safety clearance tests. And my advice for that is know the purpose of those tests. So overall, if you don't know why you're doing a test, I would recommend not doing it, because it's really not going to change your plan of care in any way. So some key points about the efficient exam here. With the efficient exam, the focus is to identify whether or not that patient is appropriate for physical therapy. And then that way we can, if they are, we can begin our education and other treatments right away. Some key points about the exam here is that we need to assess the cervical spine, of course, the CT junction, because that is a huge area in the cervical exam, and also cervical pain, thoracic spine, and shoulder. Basically, we're assessing regional areas of the cervical spine. Also, many patients with shoulder dysfunction have scapular muscle strength deficits or motor control deficits. Again, we need to go to the shoulder. We need to look at what muscles in the thorax region are helping protect and support the head and neck. And then sometimes you must know that a more detailed neurological exam may be warranted. And in those cases, we're not going to strictly follow this efficient exam sequence. So some of the safety tests and measures, I lump these all under some sort of craniovertebral scan. Now, these may not be necessary on every cervical evaluation that you perform, but it would be my recommendation to perform these on as many people as possible, because getting in the habit of performing them is going to make them faster and faster, and you're going to get a better feel of what positives versus negatives are. And I know that the diagnostic accuracy of all of these is not the best, but still getting the repetitions in of what you're stressing, why you're stressing it is great when it comes to the safety tests and measures. With this, those are the VBI test, ligament stress testing, particularly of the transverse and alar ligaments. And we talked a little bit about that with the differential diagnosis lecture, and we're going to review how to perform those in our other cervical examination lecture. The Jefferson fracture test. Jefferson fracture is a C1 fracture, and it's a burst fracture of C1. So understanding how to perform that test, which we'll get into later also. And then finally, cranial nerve screening, the cranial nerves 1 through 12, and how do we screen those? With the efficient exam, let's try to become as efficient as possible and as precise as possible when performing those 4 tests and measures. So the seated tests and measures, I'm not going to go over how to perform all these on this one, but that is outlined in our other exam lecture. But really, this is just the quick and dry of what you need to know. So when they're in sitting, first of all, you've done your subjective history. So now we're getting into the actual examination portion. And most likely, these are the things that you're going to want to perform on almost everyone. So they're in sitting, you're just talking to them in sitting and say, hey, we're ready to start our exam portion. And things that you should be looking for are neurological tests. So if they indicate any sort of neuroscreening that's necessary, do your dermatomes, myotomes, reflexes, and then also on that safety check, we talked about the cranial nerve screen. And for dermatomes, myotomes, most likely you can just get away with the upper extremity dermatomes, myotomes, and reflexes. But again, if you think it's more of a cervical myelopathy situation, which is central cord compression, then focus potentially on the whole body dermatomes and myotomes. Next is going to be static and dynamic postural assessment. And that means basically looking at them statically when they're not moving. But the dynamic postural assessment is watching their range of motion through several repetitions. So taking a look at both the neck and shoulder range of motion dynamically and statically. Cervical cardinal plane testing. So that's going to be flexion, extension, rotation, and side bending. And what I look for there is quick patterns of recognition. So if someone, let's say, has limited cervical flexion, they have limited side bending to the right, limited opening to the right, I know that either something's going on with the closing on that right side or it's an opening issue on the left. So what are the facet joints doing or not doing that is limiting that range of motion? Shoulder range of motion. Ideally, I'm just quickly looking at shoulder flexion, abduction, external rotation, and internal rotation behind the back. And my hope with this is that if the shoulder is moving well, then we can just go more towards the cervical spine. Now, there's plenty of people who are lacking shoulder range of motion, and that's placing more stress across the scapular stabilizers and across the upper trap. Something that I see quite frequently is where someone almost looks like they have full shoulder motion, but really, and they have only about 160 to 170 degrees of shoulder flexion, and the same with abduction. So when they're lacking that end range of shoulder mobility, then the upper trap has to work more. The scapular stabilizers in the back can't kick in as they need to. And then also the thoracic spine is often limited and hypomobile, especially going back into extension. The sitting special tests would be our compression, distraction, and Sperling test. Those are very quick and easy tests to perform. Also, first and second rib assessment. So we're checking that for joint mobility. That's going to be graded as normal mobility, hypo or hypermobile. And oftentimes the first and second rib might be stiff or painful with that palpatory assessment. So be aware of that. Be aware of the contributions of how the anterior middle scalene attached onto the first rib and the posterior scalene onto the second rib, and how those muscles can both pull on the cervical spine and the thoracic outlet and shoulder areas. And then finally, in sitting, the upper trapezius and serratus anterior manual muscle test. Those are both shoulder upward rotators. The upper trap is also a scapular elevator. When performing those, be precise and watch for small deviations in movement. The upper trap, I test overhead, where I shrug, I lift the patient's shoulders up towards their ears, and I want to see if they can hold that position overhead, because that upper trap, as an elevator, it works mainly in the overhead position. And then we get into the serratus anterior test in the other examination lecture. And then in supine, our supine tests and measures, cervical passive range of motion. So you've seen they're active already, and when they're in sitting, here's the passive range of motion. Also our supine special testing, potentially, if we're suspecting that they have more of a motor control movement impairment problem, looking at the deep neck flexor endurance test, the CCFT test, and then also the cervical distraction test, which is the bottom picture here, where you are checking to see if that relieves their symptoms. And that's more indicated if they're having a radiating type of pain. But also, I look at it as, does distraction take away their symptoms? If it just feels good, it's not really much information to me. But if it helps alleviate their symptoms, that means that more, if we're, put traction type of forces is what that patient's looking for. Segmental mobility testing. This is a side to side. We're looking at segment by segment joint mobility here. And with this, I'm looking for areas of hypomobility in the cervical spine. We can look for hypermobility, but mainly I'm looking to see what areas are most stiff, which can be limiting motion, and then also could be pain. It could be quick sources of pain for that person. So let's say the person has on the right side limited right rotation. What I might find is that when I'm doing the upper cervical segment of mobility, so at C1, C2, if they're limited in rotation there, that segment of mobility testing means that I might need to mobilize or manipulate C1, C2 because that's a huge contribution to cervical rotation. And then I'm also doing a side glide assessment of C2, 3 all the way down to C7, T1 because I want to see how each level is moving and if that can be contributing to why a certain movement is limited. Muscle length testing in supine is going to be the pec major and minor muscles, and those are pretty easy to check. And then also you just get a general feel for how that person's moving as you take them into different positions in supine to check the muscle length. Finally, what I think is more important even is our upper limb tension testing, and that's going to be of the median, radial, and ulnar nerves. This upper limb tension testing is very important because oftentimes people have these, I want to say, random type symptoms where we can't really pinpoint a specific structure. And by teasing out a specific upper limb nerve, one of those three nerves, it can give us so much information into just something generally that we need to floss across from the neck to the thoracic outlet area, just to get those areas moving better. Prone test and measures, pretty quick here. Mainly this is going to be some strength testing of the scapular stabilizers, and then also joint mobility of the CT junction, thoracic spine, and rib cage. This is the best way, in my opinion, to assess the CT junction and thoracic spine is with just a straight PA assessment. So you go segment by segment. I use the hypothenar eminence. Oftentimes people like to use that pincer grip, or I forget what they call this one, where we have IP flexion and flexion also. Well, thumb IP flexion and then flexion of the first finger. Hold it there and then you press down at each segment. And that's indicated in that picture on the right. But the combination of those two things is really all that I'm looking for in the prone position. With this one, I put there's an option for PA cervical segmental mobility. But as we talked about with the supine segmental mobility, you've likely got a good assessment of how they're moving segmentally already. So that's not maybe the most efficient thing to do in this situation. And then a quick note on the efficient exam. If you're suspecting chronic pain, know that anyone with chronic pain, but especially in the cervical spine, that the biopsychosocial effects play a huge role. So if they're presenting with multiple yellow flags or red flags, ensure that they're appropriate for physical therapy. And then my advice is just to get them moving as quickly as possible. Provide as much therapeutic neuroscience education, so T&E, as possible, because in addition to addressing their mechanical or musculoskeletal issues, we're also going to have to address some of the psychological and then socio-emotional aspects of their pain. And this is very real, and it's very real in individuals with neck pain for sure. So if you're thinking that it's not adding up to a specific tissue, I highly recommend you can even cut the exam shorter once you've ruled out red flags that bar that person from treatment, but then just get them moving and start giving them good education right away. A great example is someone who comes in with chronic whiplash and they're cleared, everything is okay from a medical standpoint. That person likely needs some good education and just to get moving. And it can be even movement to get them on a lower extremity bike for their neck, but we just need blood flow and good hormone response, more of a general metabolic response to hopefully desensitize this person's pain. So my final advice is be thorough and be as efficient as possible. So We often spend too much time performing unnecessary tests and measures, and think about being efficient, but also covering your bases to make sure that you're not missing anything. Thanks.